Welcome to OCD Whisper Podcast. If you guys enjoy these episodes where we talk about OCD, anxiety, and mental health, please remember to subscribe and turn the notification bell on. Today with me, I have Jenna Stone, and we're going to be talking about autism and OCD, but not just that. But I think one of the common things I heard from you guys is, what would the evaluation process even look like for that? How would you do therapy for that? So Jenna is going to talk about that with us. Welcome to the show, Jenna.
Hi, thank you so much for having me.
Absolutely. If you don't mind, just to give our audience a little background and a little bit about kind of what you do, who you are, that would be great.
Sure. So I am a licensed clinical social worker in Maryland. I'm also licensed in Virginia and Florida, and I have a private practice called SideQuest Psychotherapy here. And I primarily specialize in OCD and eating disorders with neurodivergent folks. So I also offer ADHD and autism assessments, and I use that in
Amazing.
my work with OCD.
Okay, well, let's dive right in.
Yeah.
I guess one of the things I always like to know from my guests is kind of what got you into this work? What got you interested? Like, is there a little piece of a story about you that you want to share?
Yeah, sure. So I actually became a therapist because I recovered from an eating disorder. I was struggling with OCD in graduate school and thought I would never get into OCD as a provider because it hit too close to home. And then I met other lived experience clinicians, learned ICBT, got involved in that community, and the rest is kind of history.
Okay, got it. I love it. So you have like a personal connection to this. Yeah, I get that.
Absolutely. Yeah.
Yeah. Yeah, like I have OCD. Partially why this podcast even exists at this point is really because of clients and kind of, realizing like, God, it took so long for me to even find treatment. That, like,
Mhm.
okay, let's keep talking about this and not make it so taboo and weird.
Yeah.
Um, well, okay, so let's talk about autism and OCD. So what does that evaluation even look like?
Yeah, so sometimes people will reach out to me either just coming to me specifically for evaluation, or they will be in like eating disorder OCD treatment with me like as a therapist, and I recommend it to go through that process because it actually gives us a lot of insight about what's happening for them. So as a social worker, I provide what we call like neuroaffirming evaluations. So they're a little bit different than what you would get from a neuropsych. So we don't touch like IQ testing or anything like that. We're not looking at that. We're actually looking at the social differences in autism, the sensory domains, how emotions are experienced and expressed, and things like that through this assessment called the MIGDAS 2. Um, and that's Dr. Montero's model, which is based on this triangle of how autism is basically when the amount of demands kind of on your nervous system are going to kind of bring out some of these autism symptoms. And what I see with OCD is OCD, if you have OCD, it's going to place a lot of demands on your nervous system. Like, oh, you have to wash your hands, you have to, do things over and over again. And that can really dysregulate someone even more if they are autistic.
Yeah, so let's talk about this because I've heard on the internet, let's say, more conversations about the nervous system and
Right.
of course like everything on the internet, there's these intense polarities and
Yeah.
what are we talking about? Nervous system? Like, no, that's not even a thing to discuss when we're dealing with, OCD stuff and I'll be honest,
Right.
it's a little out of my wheelhouse if we're talking about autism because I'm not as
Yeah.
well versed or trained in that. I know some basics, but like, what do you mean when you say that, when you're talking about the nervous system?
So I'm not sure if you are following, but like polyvagal theory was just debunked. However, when I'm talking about the nervous system, I'm really talking about what a lot of us who are trained in CBT models are talking about, staying within your window of tolerance. And so for me as a therapist, I like to explore what are the things that really toss someone out of that window of tolerance. For some people, it's sensory. Struggles. And that could just be like motherhood and all the noises of children. Things like that can really make someone struggle more with their mental health overall. And of course, OCD can kind of sneak in and create stories for people um, that they then kind of get sucked into. So we just want to kind of
Got
get
it.
people more at their baseline. We know like learning happens when we are in the window of tolerance. So when we're doing therapy with autistic clients specifically, we want to make sure like if we're doing the exposure therapy, the exposure in that moment, right? Like it could change moment to moment depending on what's going on for that client. If they're able to access the learning that they're going to get through the exposure.
Okay, so since we're naturally talking about that, let's dive a little deeper. So, when you're working with somebody who has autism and OCD, like, is there a certain degree of autism where you would say it might not be helpful to do exposure and response prevention? Is there some because people talk about high functioning, lower functioning, right? Things like
Yeah.
that. So,
I think we need to do away with the functioning labels, honestly, because a lot of,
mhm.
and this gets back to the assessment that I use, which is the MIGDAS. The MIGDAS is looking at how people experience, like we take in a lot of consideration for masking presentations and how much that can lead to like what we call autistic burnout. And just really people are walking around, they appear functional on the outside, but internally they're really struggling. They might do a social like a podcast, for instance, right? And then after that podcast, ruminate or something like that, just because, like, oh, was I appropriate? Those kind of things, because they're also living usually with a lot of complex trauma about maybe, being not picking up on social cues, saying things that are inappropriate, whatever that is. And that can kind of trigger anxiety post speaking spirals, whatever they want to call it. It
I
kind of looks
see.
like OCD, but it's not. Unless it turns into more of like a story where there's like a consequence and they're like engaging in more like mental compulsions, because autistic brains like to ruminate. And I think that's one of the things our therapies that we're trained in don't really acknowledge that much, is that the autistic brain really wants to make sense of things to feel safe, to even have that experience of felt safety. People need to understand, what if I'm going to, I don't know, some networking event, what are we wearing? What are we supposed to wear? How are we supposed to talk to each other? And all these little social rules, those details are so, so important for autistic people. So if they're ruminating about that, that makes sense from that kind of understanding. And I think sometimes what looks like OCD or anxiety, like generalized anxiety, is actually what we call distinct autistic anxiety. It's a very distinct form of anxiety experienced by autistic folks.
Okay, so let me make sure I'm tracking this correctly. So you're
Sure.
saying like, okay, so if somebody, let's say with OCD, we know people, well, people in general can ruminate and do, but we're talking about that people with autism tend to ruminate really in a specific way. Part of it is understanding whatever the situation is, understanding also social cues. There's also a history of course, socially, if that isn't something that's known, then there can be some consequences or negative feedback that they've gotten, and they can trying to understand what that is or why, or they can't maybe figure it out, and so basically they will tend to ruminate a lot because they're really kind of the purpose of that is just to try to understand what's going on or what's the right thing to do or how to be, from a small detail to like, okay, how should I dress then for this, or
Mhm.
best way to come and connect, etc. And like that's going to be different than in OCD, for example, when you start to feel this urge like I have to keep figuring something out because otherwise something horrible is going to happen and catastrophic or whatever.
Yeah, this is more kind of like the way I would explain this is if you're a vegetarian and you're going out to dinner with a bunch of friends to a restaurant that you've never been to before, it's going to make sense that you're going to check that menu to see if you can actually order off of that menu. That's kind of how it is for autistic people, um, is to just kind of like need to know what to expect. So they can get their most basic needs met, whatever that is. Um, could also be something more around like the sensory, a lot of like the sensory sensitivities. Is it going to be too loud? Do I need to bring my loops or something like that? These are all very reasonable things for an autistic person navigating a neurotypical
Mm.
that was not designed for them. And so a lot of the rumination that I think we see in clients actually does make sense. And we want to get curious about what they're worrying about. And is this worry. I did that the metacognitive therapy training, so I really use that language a lot too. Is, what is the metacognitive belief? That you, a lot of the times people think, well, I have to worry to feel safe, and sometimes yes, and sometimes most of the time no, like where it turns into more of like this presentation that we would want to treat. And I think sometimes as a therapist, I'm just helping people make more sense of their experience so they can actually be more prepared and confident that, like, yeah, it's okay. I'm autistic. I'm sitting here with my fidget toy, and this is totally valid. I'm not avoiding uncomfortable emotions. I'm using it to stay engaged here tonight, right? So it's kind of like that, where we don't have to, um, you know, I don't know, pathologize fidgets or whatever, because we're not leaning into the discomfort, that kind of language that I think a lot of us were trained in when we got into
Well,
this
I
work.
think too, if I may even beyond language, it's just really understanding the different ways that
Yeah,
things show up, right? Because, like you said, to your
absolutely.
point, like, look, like right now, like if we're dealing with autism, like me fidgeting has nothing to do with me avoiding a feeling. It's actually serving more as a thing to kind of make sure I'm really here, right?
Mhm.
Versus somebody with
Right.
OCD, like they're doing everything they're doing is to try to avoid and get rid of any and all discomfort. So, like when you're having both, I mean, it seems pretty important to be able to slow down and kind of discern and figure out what's going on. So,
Yeah, and like to really have language, right? Like language for what's happening. And I think really slowing things down and doing that functional analysis, like what is the purpose of this behavior in this moment? And that can look very different. So when we do have clients that have both autism and OCD, they can start to tell, this is my OCD, or no, this is an autistic need. I actually need, I'm not going to go to this event because it has bright lights and I'm prone to headaches, and I really, I'm beyond my window of tolerance for the day, or whatever kind of language they want to use. I'm out of spoons, things like that. A lot of us with autism, we also have a lot of chronic illnesses. So there's that big overlap with some major chronic illnesses. And it's just taking care of yourself and knowing what are my limits and being okay with that,
so what would
versus
you
like this
say? Like,
bad thing is
what?
going to happen.
Yeah.
Yeah.
So my question is, okay, I know you said we want to kind of do away with like high level of functioning, low level of functioning.
Yeah.
I don't know better words or language, so let me know what that is. But I am curious about, because I have some people who've come and reached out, and people I know where um being able to really communicate and have this kind of conversation to understand or figure it out sometimes is challenged. And so how do you what do you do there? How would you work with that?
Yeah, so that is actually, I would say, one of the hardest parts of my, as someone who is late diagnosed with autism and ADHD. I didn't believe it when it was first presented to me that I could have these things, because I've went my entire life masking, right? And so I think once you have that trust, that good like rapport in the therapeutic relationship, to start to breach that, like, hey, have you ever thought that maybe these things, are coming from sensory issues or whatever it is, or I'm curious why, in relation, like especially with relationship OCD, I see this all the time, and autism, because there's the social differences. A lot of the times our clients are just trying to understand social situations, and that can spin an OCD story, right? Like that can absolutely trigger OCD. um, and sometimes it's just a matter of like, I wonder if the way that you're expecting relationships to work just isn't how relationships are, and just getting curious about those kind of things and kind of sneaking in some autism language, because sometimes people just aren't open to it. And I think it's more about really checking in and being attuned with our clients, and they're like, are they ready to explore this? And you know, if you're trained to kind of explore it with them in that
So
neuro
I'm gonna
affirming way.
yeah. Well, let me pivot for a second, because we're talking about if
Sure.
you're a therapist and you're working with clients, right? Like, I mean, and
Right.
and I think that's fair, and that's its own category. But I'm also
Yep.
thinking about, like, I actually have some friends as parents,
Yep.
and they have
Yeah.
kids who are autistic, and like
And
I'm thinking of somebody where one of the kids struggles a little more than the other, and trying to be as patient as possible. And this is a kid that has autism and OCD, and it's a little bit, again, harder to communicate and get that clarity. And I mean, a lot of work
Yeah.
has gone into, understanding and doing some of the behavioral things, and also, trying different ways to communicate and also listen and kind of translate a little bit of what's being said and what is being meant. So like, when you're thinking about families and parents and dynamics like that, like what's something that parents can do with how to kind of navigate when you're seeing your kiddo and it's pretty clear, like, okay, we're now doing OCD behaviors, like, I don't know, lining certain cups and feeling like it has to have
Right.
X amount of water, because in their
Yeah.
mind with autism too, maybe like, oh, water equals something, or I have to use X amount of Kleenexes or tissues or papers or whatever it is.
Yeah, so that's a great example is that, really, my whole question is this lining up of objects bringing that person joy or distress? Like, is there that fear attached to it? And when usually what parents see when you have that overlap is that it's a bit of both, and to start to
Mm.
like ask the child, questions about like, is this enjoyable for you? And see if they're actually like, maybe they don't have the language. A lot of autistic people are alexithymic, and they just may not know that they're in as much distress as they are, which is really heartbreaking, actually. As a parent to neurodivergent kids, that is just, it's really hard to see your kids suffer like that when you know there's a problem, maybe, and they're just not really able to see that yet because they have no words. And so
So
that's where
so what do you do? How do you help them in that moment?
the parent or the child or the
Well,
whole
how would you, I
family
guess, help the
system.
parent to support them to help the child, right? Like, so am I hearing you like help to give language, even give
Yeah,
examples like,
language.
oh, is it this or this, or is it that or
Yeah,
that?
I think just getting curious with kids about, what they're experiencing, because to just like as a therapist, we can see a behavior and get it wrong, and that we really want to trust our clients. Just as parents, we want to trust our kids to kind of give us feedback about what's actually going on, and not falsely accuse like, oh, it's the OCD monster, and it might actually not be, or it is, and we just want to kind of figure out what's going on, so we can connect them to the right kind of supports, the therapists that are actually trained to, treat OCD if this is OCD, and if there's also autism, someone who's neuroaffirming and will pace their treatment based on their neurotype.
And so so again, I'm thinking of course, if you can, because I'll be honest, I think I've seen a very small amount of folks who really understand and I think are skilled to treat both at the same time, where you don't need to go to, because for a long time it was like you have to go to an OCD specialist or a separate autism specialist. And now we actually are seeing more where, a person can actually hold both, which is amazing. Um, but if, let's say, you're not there yet, what can the parent and the child do on their own? How can they start with, okay, we've identified that this isn't necessarily just pleasure. This is, I'm
Right.
having some sort of a fear or something around it. Like,
I
what
kind
do
of
you do
think
next?
I put on my space cap for this one, where I really go into, we don't want to, as parents, we don't want to accommodate the anxious driven behaviors, right? And so usually what I see in these family systems, not all of them, but the parents are also very anxious too, and working toward lowering those accommodations when they see their kid in distress, the ones that are
Got it.
more
So even
OCD
if your
driven.
kiddo is autistic and has OCD, I mean, yeah, and then you kind of see and identify that, okay, this is some OCD stuff, then you want to kind of work with the parent, or you'd want to see the parents start to learn how to step back a little bit and not kind of
Yeah, and
go in
manage their
immediately
own
to like save.
anxiety. Yeah,
I
yeah.
mean, for sure.
Yeah, it's hard. It's really hard. And I think Space does a wonderful job of really explaining like why accommodations over accommodation is actually going to make it worse. And so the parents actually have a lot of power in helping their kids by lowering those accommodations for the anxious behaviors, and then maybe encouraging, like, if someone's kid likes to line up their cars or their Legos or put them in rainbow order just for fun, then, like, noticing that they're doing that, and like, and they know that it brings their child joy, like, wow, I really like what you're doing there with your Legos. That's really cool. You're so creative. And giving those positive, feedback statements for the autistic behaviors that will probably, um, I have a very strengths based approach with, like, looking at autism. I don't use the deficits. Like, yes, living with autism is very hard. At the same
Yeah.
time, there are things that our brains can do that are unique and different, and I think feeling like really affirmed and embraced in those ways, those beautiful ways that autism can show up, is a really great way to parent a child. And then when they are struggling with OCD, like, hey, I love you and I know you don't have to go check. And I'm gonna, stop driving you to school every morning, and whatever the accommodation is, right? And like, I know you got
Hmm.
this because you're strong.
I love that. Yeah. So still bringing that back in, and really, like you said, focusing on the ways that the person is able to, yeah, use some of those other things that they're actually interested in, and just because it brings them joy or helps them feel better, whatnot. And like, yeah, that's awesome that you know what that is and you're doing it right now, because that's actually a good thing to do.
Mhm.
Yeah. Is there anything else from your experience you could think of that would be valuable for folks to hear in terms of, how else, because I'm thinking also, I've had several kind of DMs and messages from parents about, like, gosh, I don't know what to expect. Like, do it, like, is it ERP? Is it ICBT? Is,
Mm,
like, what are we doing? What kind of therapy? Like, is it better to maybe not sit and have to kind of do all this processing kind of thing? Not even processing, but a
right.
lot of this kind of back and forth, kind of high level cognitive stuff. If maybe sometimes it seems like we can access, sometimes maybe we don't access it as well. Like, is a more ERP kind of based approach better? How do you augment it? Like, what would you say?
I think first we want to find out, like, where is the child. When kids are in burnout, I don't recommend ERP. It places way too many demands on their nervous system. Though it can be done, I'm not going to say it can't. I have to make sure, like, at least the way I work, like, my clients are totally on board. Like, they have full. Our hierarchy doesn't look like a hierarchy. It kind of changes every week, whatever we're working on, because we're really just like, kind of like, where are you at today? What do you want to work on? Progress just isn't linear with this population, and that's okay, and we have to be
Hmm.
okay with that. And I think that's actually like a big thing to tell parents, is that this expectation that your kid's going to start ERP and just kind of work up this hierarchy, and it's not like that. It's a longer process for kids with these kind of brains, and I think just being okay with that,
Hmm.
and then sitting in the grief of that, right? Like, it's so hard, especially when you are a parent and your kid has all these issues, and then maybe your friend group, their kids are like doing normal stuff or whatever, and and you're like taking your kid to their occupational therapist and their mental health therapist, their psychiatrist, and just running around to all these different appointments. That can be really hard. And so, like, sitting in the parents grief with them, we're not there to just fix it and make the feelings go away. That's not how being human works. We have
Yeah.
life can be really uncomfortable. I think, like, I love ACT. um that's another, like,
Hmm.
good approach, just like for the parents sometimes who are struggling along this journey with their kid. But, like, I have seen, now I work as young as 10 and up. I don't do ICBT with kids that young, but I have seen other therapists that have done it successfully. But I do like ICBT a lot. It's just really depends on the kid, I think, and cognitively where they're at, like, if this makes sense. Sometimes I will just do just neuroaffirming treatment, just kind of like a lot of playing Lego, whatever it is, magnetiles, just kind of like really connecting with them and establishing that. I spend more time on the rapport building before we can start to even talk about exposures. That's what I mean when I say, like, it takes longer. Sometimes that you're
Got it.
just building that rapport, and that so they feel safe and attuned, and with you, and you're not just this scary person like you have to, do these exposures to get better. You're never going to get better. That's not going to work. And we really just collaborate like, wow, like I wonder, do you think, you want to go out and try this exposure or something like that, and then get their buy-in that way, just by building that connection while we play
Got
Lego
it.
or something like that. Yeah. So a lot of like
That's cool,
play
actually. That's
therapy.
really cool to hear. Yeah. That like you really like with this population, you take your time to build and create that sense of safety and like that there's a mutual understanding. There's no rush. There's no kind of goal like in the same way you might work with somebody else and then when you kind of built more of that and that kind of bond and connection, then like you said, to your point, kind of the hierarchy or whatnot
Yeah.
it'll change because it's whatever's in that moment.
Yeah,
Okay.
so the way I explain it to a lot of my clients is, so I grew up doing figure skating, and when, we would go out there and try like double axles or whatever, they would put us on a
Hmm.
harness, right? The coach would like hold me on a harness on the ice, and I as a therapist, I feel like a coach when I'm doing this kind of work. Like I'm just
Oh
holding my
yeah.
client and like I'm not going to let you fall. We're never going to do an exposure that I know you can't handle in this moment. And that,
Hmm.
we're really creating like this safety so that they can access this learning that happens from, wow, the bad thing didn't happen. I can do
Yeah,
hard
so even
things.
if you do like little increments, that's like that's the name of the game, is to build some of those wins and successes so they can feel like, okay, I'm getting some confidence around this.
Yeah. Yeah.
Love it. I love that. Thank you so much for sharing all this. And I super appreciate you being open about yourself. You've included yourself in this sharing process. And
I'm pretty
um,
open these days.
I love it. I mean, I think it's great to hear directly, from somebody who's actually living the experience, and kind of what that's like. Yeah. So for anybody who would like to find you, how can they find you?
Yeah, so I am, like I said, I'm based in Maryland. On Instagram, my practice name is SideQuest Psychotherapy, and then my actual account is SideQuest with Jenna. I don't know what my TikTok username is, to be honest. I think it's one of the same, but I'm out there. You can find me. I'm also on Substack under Jenna Stone. So yeah, thank you
Awesome.
so
Well, thank
much
you
for
so
having.
much for coming on the show.
Yeah, absolutely.